For the kind introduction, Yanri. Ladies and gentlemen, it is a privilege for me tonight to provide an overview of our discipline and also to give some basic insights into the daily practice of cyto and histopathology. In order to do so, I will emphasize various topics, and this will range from our definitions to the differences between the disciplines, the purpose of cyto and histopathology, the types of samples we receive, tissue processing and sectioning, and then we will talk about the science and art of rendering a diagnosis. So, let's kick off. Concerning definitions, anatomical pathology entails the study of diseases which affects the cells and tissues of the body. Simply put, it is cell and tissue pathology, in other words, cytopathology and histopathology. Other disciplines of pathology also include hematology, immunology, chemical pathology, microbiology, virology, and of course, molecular pathology. The practice of cyto and histopathology is performed by both macro and microscopic examination. This is not by way of machine analysis. It is based upon what we physically see. In other words, what does the tissue look like and how does it differ from normal tissue? It involves both analysis and interpretation. And yes, it is labor intensive and a hands-on discipline. So now regarding the purpose of histopathology. We analyze cells and tissue by way of objective criteria and subjective interpretation in order to provide specific information to our submitting general practitioners and specialists. This information allows the referring doctors to correctly treat their patient. In other words, our referring doctors are consulting us for an opinion in order to help them manage their patient optimally. And a good example of this is a pigmented skin lesion. Here we see an unusual pigmented skin lesion, which may either be benign, a nevus, or it may be a malignant melanoma. Under the microscope, a benign compound melanocytic nevus shows delicate small nests at the dermoepidermal junction and also within the dermis. But contrast this with malignant melanoma, one can appreciate expansile nests of tumor cells which appear discohesive, and the nuclei appear enlarged and demonstrate nucleoli. This specific information consists of the following: explaining the nature of the disease. That is, what is it or what is wrong with the patient? This is the diagnosis. We provide information regarding possible complications of the disease. This obviously impacts morbidity and mortality. We comment on possible spread of disease to other parts of the body. As an example, we remark upon the presence or absence of lymphovascular invasion by tumor in cancer resection specimens. This specific information also enables the doctor to understand the probable course of the disease. In other words, the prognosis. And this is what the patients also want to find out. So yes, to a large extent, we are considered the gold standard in diagnostic medicine. We guide the surgeon's hand and direct the oncologist's plans. A doctor acts definitively based upon what we say. For instance, cancer or not cancer, and the implications thereof. And as I have said, this is all based on human assessment. So there is really no room for error. Or is there? But we will touch on this a little bit later. Right, if we move on to the types of samples we receive. Samples are called specimens. Cell samples constitute cytology, and tissue samples, histology. If we kick off with the cytology samples, the best example of cytology is the pap smear, which we refer to as gynecologic cytology. Non-gynecologic cytology includes fluids such as urine, pleural fluid, ascitic fluid, cerebrospinal fluid, as well as cells aspirated from various organs, such as the thyroid, the breast, lung, liver, pancreas. I think it is important here to mention that cytology is primarily a screening tool rather than a standalone or absolute diagnostic parameter. These are just examples of our gynecologic cytology specimens. Here we have a thin prep, liquid-based cytology container, and here we have a Histopath container with the endocervical brushes. I'm sure most of you are accustomed to these. Here we have just an example of our cytology processor. The cytology fluid with the cells therein is aspirated by the machine and then dispersed on a glass slide. This glass slide is then stained. In our laboratory in Bloemfontein, we do this manually. And then we end with the final product. On the left is a liquid-based cytology, a pap smear. One can see a thin rim of cells evenly dispersed. On the right is an example of a conventional pap smear, not liquid-based. I think here one can maybe appreciate thicker areas which sometimes impede accurate cytologic review, which then the liquid-based does not have, and that is its advantage. Just a few images under the microscope of gynecytology. On the top left, we have squamous epithelial cells, which are completely normal. And on the top right, we have endocervical epithelium. It is usually important for us to mention the presence or absence of endocervical cells in a pap smear, because this denotes adequate sampling of the transformation zone where dysplasia usually arises. On the bottom left, we can see an example of herpes simplex infection on a pap smear. Cells are multinucleate, and if one pays attention to the nuclei, there is a ground glass appearance owing to the chromatin which has been pushed to the side. We call that chromatin margination. On the bottom right, one can appreciate some fungal hyphae of Candida. Still with the gynecytology, on the top left, we have an example of a low-grade squamous intraepithelial lesion, or what we call L-cell. And on the right, H-cell, a high-grade squamous intraepithelial lesion. The cells here demonstrate nuclear enlargement. The nuclei appear darker, which we refer to as hyperchromatic. And the nuclear to cytoplasmic ratios are also increased. On the bottom left, we have an example of squamous cell carcinoma on a pap smear. Here, the nuclei demonstrate small nucleoli and the cytoplasm is denser. And on the bottom right, we have another example of endocervical adenocarcinoma of the uterine cervix. Concerning non-gyne cytology, the top left is a Giemsa stain of CSF. This particular patient has acute lymphoblastic leukemia, and one can appreciate the lymphoblasts with their highly irregular and enlarged nuclei in the cerebrospinal fluid. On the top right, we notice an FNA of a lung mass, which was diagnosed as adenocarcinoma. On the bottom left, which is a beautiful example of papillary thyroid carcinoma. In this particular aspirate, one can actually see small nucleoli, but also in that image, towards the bottom right, one notices a nuclear pseudo-inclusion, as well as in another cell, a nuclear groove. And these are telltale signs for papillary thyroid carcinoma. Then the last image on the bottom right is an aspirate from a breast mass. This is ductal carcinoma, and it is characterized by a hypercellular aspirate of discohesive tumor cells showing nuclear atypia. If we move on to histology, skin biopsies represent our most common type of specimen received. But gastrointestinal biopsies, these being 2 to 3 millimeter in size, are also frequent. Besides endoscopic biopsies and skin samples, we get biopsies from lymph nodes, from the lung, the breast, liver, prostate, and even entire organs, especially with resection specimens, for mastectomies, colectomies, thyroidectomies, pneumonectomies, hepatectomies. The list carries on. This is the start of our day in our histology lab. One can see a couple of small specimens and then some larger specimens in 5-liter containers. And here are just to illustrate a couple of examples of the samples we receive. Here's a pigmented skin lesion. On the right, one can see this is how we bread loaf the specimen in order to increase the number of slides that we can view the case with. And the blue represents the ink in order to establish if the lesion is adequately excised. Here is an example of a hemihepatectomy for a hepatocellular carcinoma, presenting as a solid circumscribed mass, and this has quite a variegated color upon sectioning. This is an example of a hysterectomy, anteriorly sectioned, with both adnexae attached, and in the center of the uterus, in the region of the fundus, one can appreciate a fleshy tumor. This was an endometrial adenocarcinoma. This particular case represents an adrenalectomy for an adrenocortical adenoma. If one carefully examines the periphery, one can see the compressed adrenal gland, and the tumor itself is round and circumscribed and yellow. Contrast this with another adrenal tumor. This is a pheochromocytoma, and this was a young gentleman that presented with secondary hypertension. Another example here is a total mesorectal excision for a low rectal adenocarcinoma. One can see the tumor appears sessile and fungating. It involves almost the entire luminal circumference, yet it is also clearly demarcated from the background colorectal mucosa. One can also notice the green ink on the right side in order to establish whether the tumor is adequately excised. Last example that I can maybe show is a nephrectomy specimen for hydronephrosis. This particular instance, the patient presented with a mid-ureteric urothelial carcinoma, resulting in obstructive uropathy. And one can appreciate the dilatation of the renal pelvis and the calyceal system. This was a non-functioning kidney, which was also removed during the nephroureterectomy procedure. Right, if we start with tissue processing. Processing and preparation takes several hours to perform. This ranges from a minimum of 5 hours to a maximum of 15. And it is important that I stress this is the nature of our discipline. It involves tissue fixation, cut up, processing, wax embedding, microtoning, staining, and mounting. So let's kick off with the tissue fixation. For histology specimens, as you all are well aware of, these specimens are placed in 10% neutral buffered formalin solution. The purpose of the formalin is to preserve the tissue. Otherwise, the tissue becomes degenerate, which we call autolytic. And this makes it completely unsuitable for us to examine and render a diagnosis. Our recommendation is a minimum of 4 hours formalin fixation, and larger specimens are allowed to fix overnight, so minimum of 12 hours. There are other fixative solutions which have been used in the past, Bowens and Zenkers, and those, if I recall, were mainly for testis biopsies. Concerning tissue fixation for our cytology specimens, as I've already shown, we have liquid-based cytology fluid for our pap smears and for non-gynecologic cytology samples. But if tissue is aspirated and put on a slide, one can use cytofix and cytospray to preserve the cellular material. Right, now we move on to our cut-up or our dissection or grossing. And this is what a histopathologist sees with the naked eye. As I've mentioned, we can have small endoscopic biopsies or larger, complicated cases. Our dissection is done according to internationally accepted protocols. In other words, we describe the nature of the specimen, the size, the shape, the color, consistency, and importantly, the relation to adjacent structures. The cut-up is done in batches in our laboratory twice a day, and the tissue that is dissected is placed into histologic cassettes. This is an example of our cut-up bench, and the grey background represents our extraction system to remove the toxic formalin fumes. As I also mentioned, cut-up is done according to protocols. The surgical pathology dissection guide is produced by the Johns Hopkins group, and this is quite useful in complicated cases, such as in a Whipple procedure. And this is what our histology cassette looks like. Right, now that the tissue is in the histology cassette, the tissue is loaded and placed in a tissue processor. And the purpose thereof is to solidify the tissue to allow for sectioning and staining the following day. Tissue processors, there are many on the market, such as TissueTech and Leica. And what happens here is the tissue is exposed to varying concentrations of alcohol and xylene. It occurs overnight, and this process takes up to 12 hours. Occasionally one can short process, but this is only for very small specimens. And then of course there are certain models on the market which make use of microwave processing. Here is our TissueTech VIP processor in Bloemfontein. Our technologists have lovingly named him SpongeBob. All right. Now, following tissue processing, we move to tissue embedding. This happens the following morning. So this involves placement of the processed tissue in a wax mold. Wax hardens the tissue for delicate sectioning. The importance of embedding relates to the correct orientation of tissue. And I will illustrate this as follows. This is just an image of our embedding machine. On the left is the cold plate, and in the center is the nozzle through which the molten wax comes out. And this is the wax mold with a section of tissue in it, fixed to the histologic cassette in the background. Now, to illustrate the importance of correct embedding, here is an example of another colorectal cancer presenting as a polypoid mass. One can appreciate the slices that we have already made into the tumor so that we can produce a cross-section. On the left, one can see normal colorectal mucosa, which moves across into a deep ulcer, which represents the tumor. The importance thereof can be seen on the following microscopic slide, where one can appreciate the relation of the tumor effacing the muscular layer of the bowel. This refers to tumor stage. If tissue is embedded incorrectly, we are unable to remark upon this, and then this information is not available to the oncologist, as this will influence both treatment and prognosis. Following the embedding, the tissue is then sectioned on a microtome. We produce extremely thin slices of tissue, 2 to 4 micrometer in thickness. These tissue sections are floated on a water bath and then picked up on a glass slide. At this stage, they appear clear to. Here is an example of our rotary microtome. All the wax shavings can be seen at the bottom, and then just to the right of the microtome, one can see our water bath. Now, these slides with the unstained tissue sections are then placed in an incubator for a brief period and then are transferred to a rack in the automated stainer. Staining is done with varying concentrations of alcohol, hematoxylin, Scots eosin xylene, and this produces our H&E slide, hematoxylin and eosin. So we see varying colors of pink and blue. And this is simply a factor of the tissue components represented on the slide. Once stained, a cover slip is placed on the slide. This can be done either manually or also by an automated process. And here is a photo of our automated stainer. Towards the right, one can see a vertical mechanical arm which moves the slide through the varying concentrations of hematoxylin, alcohol, Scots eosin, and xylene. And this is our end product. On the left, we have a section of a renal cell carcinoma. In the middle, a section of an endometrial adenocarcinoma. And on the right, we have a cross-section of a skin excision for a basal cell carcinoma. The following image is an oblique sectioning of an appendix, and one can appreciate the lymphoid follicles at the top. But this image highlights both the science and the art of rendering a diagnosis in histopathology. And this is what we will talk upon a bit more now. So the question you may ask is it easy to make a diagnosis? Simply put, yes and no. We have a vast and varied field of study. Each organ system has its own specific set of diseases and pathologic processes. And to make matters worse, diseases do not read textbooks, as we all know in medicine. Diagnoses are not always black and white. So not all cases fit snugly into a particular category, which usually results in the following. Concerning the science of rendering a diagnosis. As I have already mentioned, it is based on human assessment, which is obviously subjective at times, not machine analysis. We do this by way of light microscopy. And we render the diagnosis by way of pattern recognition. In other words, we have seen this before and we know what it is. Or we have to evaluate using evidence-based objective criteria. The tool of the trade is the light microscope. This particular one is a double header where two pathologists can view the same slide at the same time, and this is very helpful in difficult cases. The science of the diagnosis to continue. This is aided by the use of special stains, immunostains, which we refer to as histochemistry and immunohistochemistry. These stains are performed on tissue sections from the wax block, and they highlight unique characteristics of the tissue to enable a final diagnosis. Obviously, diagnosis is also aided by asking assistance from experienced colleagues and super specialists in a particular field. To say a few words on histochemistry, our special stains. This is periodic acid Schiff, PAS or PAS and PAS diastase. On the far left, it highlights fungal elements in an esophagus biopsy. So this is esophageal candidiasis. One can appreciate the pseudohyphae and the spores. In the center, the PAS diastase stain identifies neutral mucin within glandular lumina in a case of adenocarcinoma of the lung. And on the far right, if one has a closer look, one can see small eosinophilic globules highlighted with PAS histochemistry. This is a case of Kaposi sarcoma. Silver staining. On the far left, our Grocott stain identifies crescent-shaped and cup-shaped cysts of Pneumocystis jirovecii in a lung biopsy. In the center, a silver stain can demonstrate the thickness of the basement membrane in a renal glomerulus, in a case of membranous glomerulopathy. And on the right, our reticulin stain enables one to view the trabecular network of a hepatocellular carcinoma. The von Koster stain identifies calcium. This is a skin biopsy with the epidermis at the top, and in the dermis beneath, one can see black staining material. This is calcified elastic fibers in a condition known as pseudoxanthoma elasticum. Mason trichrome histochemistry is used to stain collagen. This is a case of collagenous colitis. It results in a chronic diarrhea in the presence of unremarkable colonoscopy. On the top image, the H&E slide, one can appreciate pink material beneath the mucosal surface. And on the Mason trichrome, it stains blue, indicating it is collagen. Alcian blue histochemistry. This identifies acid mucopolysaccharides, also called hyaluronic acid. This is a skin biopsy of a patient with lupus, where there is increased mucin in the interstitium, in other words, between the dermal collagen bundles. Here is a Prussian blue stain. Now, this is very useful in liver pathology. It identifies iron, and this is a case of hereditary hemochromatosis, with accumulation of iron in the form of these granules in the hepatocellular cytoplasm. A Congo red special stain. This identifies amyloid, and this was a case of a patient with a medullary carcinoma of the thyroid, in which amyloid is often produced. Although the image doesn't present it very well on the top, it usually stains orange on H&E, and then one can see beneath on polarizing microscopy. Amyloid has a characteristic apple green birefringence. Finally, just to mention two additional special stains, we have the ZN stain to identify mycobacteria. These are beaded acid and alcohol fast bacilli in case of tuberculosis. And then we have a Giemsa stain or methylene blue stain, which one uses to identify Helicobacter pylori organisms on the surface of the gastric mucosa in a case of gastritis. I think if one looks quite carefully, one can see the small organisms that stand out there on the surface. Just to mention something about immunohistochemistry as an aid to making a diagnosis. This is a specialized technique which uses peroxidase labeled antibodies to detect specific antigens in cells within a tissue section. So it is based upon antigen-antibody interactions. It is also performed on the routinely processed tissue sections, and then this reaction is visualized under routine microscopy with the aid of a marker, which we call a chromogen. It is usually brown in color. It can also be red. The chromogen is tagged to the antibody, which will bind to the antigen of interest. The antibody may label either the cell membrane, the cytoplasm, cellular components, or the nucleus. This is an example of our immunohistochemical machine we use in Bloemfontein. The larger labs make use of much more impressive models. And this is simply a schematic representation of the antibody-antigen interaction. Right, as I said, immunohistochemical stains label certain parts of the cell. Here is an example of cell membrane immunoreactivity for HER2. This is a case of duct carcinoma of the breast. And one can see distinct cell membrane staining. When a breast cancer expresses HER2 immunohistochemically, and this is often confirmed with in situ hybridization, the oncologist can treat the patient with Herceptin. Here is an immunohistochemical staining for cytoplasm, and this is a stain we use quite frequently, cytokeratin. It identifies the tissue as epithelial, and for us that would translate as carcinoma in tumor pathology. Cell components can also stain with immunohistochemistry. This is a neuroendocrine tumor, and although it looks like cytoplasmic staining, the chromogranin A is labeling the small neurosecretory vesicles within the cytoplasm, but the brown staining indicates it is positive. And then lastly, nuclear staining. Soxtine is a very useful immunolabel for melanocytic and neural tumors. This case was an undifferentiated tumor which eventually labeled with SOX10, and this meant it was a malignant melanoma. Right, now we move to a bit more philosophy concerning the art of diagnosis. And I will deal with some topics from misconceptions all the way to some post-analytic factors. Right, misconceptions. One of the most common is the mistaken belief that histopathologists are required to invariably render a categorical and unequivocal diagnosis at all times. Pathology is not always as simple as black and white, but more like different shades of grey, or in our case, shades of pink and blue. At times, the best diagnosis is the ability to convey to the clinician in our pathology report the correct approach to follow in the further management of a patient. And at times this relates to the personality of the pathologist. Sometimes a pathologist is more conservative in rendering a definite diagnosis or more aggressive. And we often refer to this as being a dove or a hawk. Another misconception of our discipline is that we are able to render a diagnosis without any clinical information. And by this I mean often no information is given concerning the site of the biopsy or the aspirate sample. No history is provided regarding previous possible cancer diagnoses. Unfortunately, nursing or theatre staff complete requisition forms incorrectly. At times, handwriting is illegible, and we have even received specimens with no doctor or patient information provided. So truthfully, the submitting clinician remains primarily responsible, as the pathologist is being consulted in order to arrive at the correct diagnosis for the benefit of the patient. Another misconception entails our turnaround time, or the expectation of turnaround time. Many clinicians are unaware of the time required for adequate formalin fixation and tissue processing, and I hope I have explained that. The College of American Pathologists, the CAP, remarks on an analytic TAT of 2 days or less, and by that I mean once the case lands on our desk. Several factors also influence our turnaround time, and this would depend on the type of specimen, in other words, a complicated case, the number of slides, the need for immunohistochemistry, and of course, consultation with colleagues when confronted with a difficult case. But I need to stress that when turnaround time is delayed, the onus is on us as the pathologist to remain in regular communication with you, the clinician. And this is also important for the patient. The next misconception I just want to touch on is the use of the word atypical. So what exactly do we mean in a report when we say atypical? Actually, what we're saying is it is not typical. In other words, not normal. Please note, the word atypical doesn't with malignant. It is also the responsibility of the pathologist, in my opinion, to qualify the atypia. In other words, is it reactive/inflammatory, or is this atypia neoplastic? If a pathologist does not do this, I'm afraid confusion ensues. Unfortunately, there are those instances where one is unable to reliably establish the nature of the atypia, which leads to this. Given this, several organ-specific terminologies for atypical lesions are in our literature. One is melanocytic tumor of uncertain malignant potential, or MELTUMP, but this has not really gained much traction since the time it was proposed. But atypical ductal hyperplasia, ADH, in the breast, indefinite for dysplasia in the gastrointestinal tract, and small acinar proliferation in the prostate are well-known concepts. This is called ASAP or ATIP. And here I would just like to illustrate an example of a prostate needle core biopsy with a few unusual or atypical glands. The nuclei are slightly enlarged and they have nucleoli, but there are just not enough glands to call this cancer. At the same time, the glands are worrisome, so one cannot ignore them. Therefore, we use the term atypical small acinar proliferation. If I return to the previous slide, the last three terms, this is terminology. It is not a diagnostic entity. And this terminology usually guides the clinician in the further management of the patient. In the case of ASAP, this usually involves a repeat prostate biopsy within 6 months to a year. Concerning workload volume, as in all fields of medicine, excessive workload volume will impact negatively, and this will impact negatively on our diagnostic accuracy. This is just a fact. In order to navigate this issue, a pathologist needs self-discipline, which is dependent on his or her personality, their time management skill, a logical approach to the caseload, and then, of course, family support, which is most important. Another issue I would like to discuss is the representative nature of the sample. Now, this is a crucial concept to understand. I would like to say that if the clinical or the radiologic findings remain consistent with the diagnosis of malignancy, the absence of malignancy on a biopsy should prompt rebiopsy. It does not mean that the tumor is not there. It may mean the tumor has just been missed. At times, we are unable to fully categorize the nature of a tumor on limited needle core sampling. And by this, I refer to soft tissue sarcomas and lymphomas. Tumors inherently may show cytoarchitectural variation, which is not always available on limited material, and which may clinch the diagnosis for us. And that is why we often put in a comment that a final diagnosis is deferred to the excision specimen. And I would like to illustrate this by way of a few examples. This is a myxofibrosarcoma. This is a soft tissue tumor. On the left is the incision biopsy. Here the tumor appears low grade and hypocellular. Yet on the right, with the excision biopsy, it was high grade and much more cellular with more pleomorphism visible. Here is an example of a Hodgkin lymphoma. On the left was a needle core sampling, which missed the Hodgkin lymphoma, which only partially involved the lymph node. But on the formal lymph node biopsy, one can clearly see the Reed-Sternberg cells on the right. They are mono and binucleate, typically owl eye appearance. Here is another example. On the left, we have an endometrial curettage. This was reported as endometrial hyperplasia. However, with the follow-up hysterectomy, one can clearly see the invasive adenocarcinoma involving the myometrium, and this was obviously not available on the curettage material. Concerning the spectrum of our diagnoses, well, this ranges from simple cases to complex cancer resections, to very rare and unusual tumors. And just to illustrate, on the left, we have a garden variety intradermal melanocytic nevus in the skin. On the right, we have a rare succinate dehydrogenase deficient renal cell carcinoma. It really covers everything, from the mundane to the insane. Concerning diagnostic difficulty and errors, given this wide spectrum of disease, we are ever aware of the potential for misdiagnosis. Minor diagnostic errors and subjective disagreements are not infrequent, and these do not influence patient prognoses or further management thereof. However, major diagnostic discrepancies will impact adversely, and in order to ensure diagnostic accuracy, we make use of regular internal and external quality control programs. Just to illustrate an example, on the left we have a proliferative actinic keratosis, on the right superficially invasive squamous cell carcinoma. Both look nearly identical and both are treated similarly. So should there be a minor disagreement, this is considered acceptable. In contrast, here we have on the left a T-cell rich large B-cell lymphoma, but on the right Hodgkin lymphoma. One can appreciate these look nearly identical too, with atypical lymphoid cells set against a sea of small reactive lymphocytes. And this is what makes our discipline quite complicated. The next concept I want to mention is clinical correlation. A pathologist cannot make an accurate diagnosis in isolation. And when we use this phrase in our pathology report, it is actually an instruction to the treating clinician to kindly correlate our findings with the clinical, biochemical, and radiologic picture. Put it all together to arrive at the correct diagnosis. And the reason we say this is because certain reaction patterns in histopathology are similar despite different etiologies. Let me explain. This is an example of gestational change in the endometrium. On the left, we have hypersecretory glands, and on the right, we have decidual change of the stroma. In the case of a uterine evacuation for products of conception, or for a miscarriage, if we do not see products of conception under the microscope, in other words, we do not see placental tissue and chorionic villi, yet all we see is gestational change, we need to alert the clinician, being the gynecologist, that this finding is not only seen in intrauterine pregnancies, but can also be seen in ectopic pregnancies. In other words, if this is the only finding, one must go back and make sure an ectopic pregnancy is not missed. Hence, clinical correlation. Another example, cutaneous perivascular lymphocytic inflammation. This is a skin biopsy, the epidermis at the top, and in the dermis one can see a tight infiltrate lymphocytes around the blood vessels. This reaction pattern is very common, yet non-specific. It can be seen in cases of drug reactions, rickettsial and viral infections, lupus erythematosus, the annular and gyrate erythemas, lymphocytic vasculitis, leukemic vasculitis, perniosis. The list is endless, hence clinical correlation on the part of the dermatologist. And granulomatous inflammation. This is a lymph node biopsy. One can appreciate well-formed epithelioid granulomas. This can be seen in cases of infection, whether it be tuberculosis, fungal infection, leprosy, brucellosis. It can be seen in sarcoidosis. It can be seen in foreign body cases, foreign body granulomas. So if our special stains do not highlight an infection, we are compelled to ask the clinician to kindly correlate clinically, could this not be infection or sarcoidosis? And then just something very briefly on post-analytic factors. And by here I refer to the reporting styles amongst varying pathologists. It's usually free text or it can be synoptic. In free text format, the content of the report should ideally express the logical manner in which a diagnosis was reached. If not, the free text format sounds clumsy or ambiguous and results in confusion. Regrettably, occasional spelling and grammatical errors do sneak into free text format reporting. The synoptic reporting, this usually entails checklists. It is easier, and this includes protocols for cancer resections, such as those endorsed by the College of American Pathologists. And here is just an example of the protocol that we will follow for invasive breast cancer. These protocols are usually updated every 6 months to a year by the CAP. I would like to end then by just to mention something about frozen sections. The purpose of a frozen section is to provide an intraoperative diagnosis. This occurs during surgery, as many of you may know, while the patient is under anesthesia. The sample tissue is frozen in order to harden it, very much similar to the wax, although we do not have that available at theatre. So the tissue is in a frozen mold. It is sectioned and stained, and we provide a rapid diagnosis. We are literally put on the spot. There is no time for consultation of textbooks or with colleagues, and it is a very stressful exercise, which is why certain pathologists refer to it as pathology in the trenches. The literature remarks that a pathologist requires the following qualities in order to make the correct decision at frozen section. Please note, I say correct decision, not necessarily correct diagnosis. One needs knowledge of pathology and clinical medicine, that's obvious, but experience is invaluable, and common sense is even more crucial. A pathologist must also be aware of the limitations of frozen section, and this relates to what are the correct indications. And lastly, with no disrespect intended, resolve on the part of the pathologist not to cave in to the occasional unrealistic expectation of providing a conclusive diagnosis. With the advances in medical technology and clinical practice, the reasons for requesting an intraoperative frozen section have changed over the years. But I would like to refer to the guiding principle of one of the pioneers of modern surgical pathology, Dr. Lauren V. Ackerman. There is only one purpose in the frozen section, and that is to make an immediate therapeutic decision. The result directly influences the surgical procedure, so here there is no room for error. Concerning indications, frozen sections are requested to identify a tissue type. Here I may mention an example of a patient with a parathyroid adenoma. However, during exploratory surgery, a parathyroid adenoma in the neck may resemble a lymph node, and we are called to identify the parathyroid tissue so that the surgeon doesn't remove a lymph node and leaves the parathyroid adenoma behind. Frozen sections are also requested to establish the presence and nature of a lesion. An example here is in breast cancer. For instance, a female patient clinically presents with a breast tumor. It's clinically cancer, but upon radiology, the results are inconclusive, and also cytology. And that is when a frozen section is requested. And then based upon what we say, a lumpectomy or a mastectomy may follow if it is malignant. Frozen sections are also requested to discriminate between benign versus malignant tumors, although it's not always possible to type the specific malignancy. Here I may mention an example of a testis mass in the epididymis. A benign tumor is, for instance, an adenomatoid tumor. And if that is the case, a simple local excision will suffice. However, it is a germ cell tumor, one has to do a completion or pedectomy. More indications include to determine whether the tissue obtained contains diagnosable material. This is important in central nervous system tumor pathology, where it is often difficult at surgery to discriminate between a low-grade glial neoplasm and gliosis at the periphery, which occurs in the adjacent cerebral cortex. Frozen sections are often requested to determine the adequacy of surgical margins, and where appropriate and within reason, since it is not practically nor technically feasible to examine all surgical margins. And of course, to determine the presence of metastases in other organs. For example, in a sentinel lymph node biopsy in breast cancer, if positive, a completion axillary dissection will follow. Or in the case of carcinoma, in the presence of a liver metastasis, further surgery will most likely not be done. And this is just to end off with images of what frozen section diagnosis looks like. On the left, we have our metallic disc. In the middle at the top, we have the tissue, which is now being placed in OCT. This hardens the tissue to form a frozen background. And then on closer inspection, in the chuck of the microtome, we can see the tissue embedded in the frozen OCT. It's being sectioned on the blade and then put on the glass slide. Here is an example of a photomicrograph of what a frozen section image looks like. As opposed to the other images, it's often a little bit fragmented, but in this particular case, one could make the diagnosis of adenocarcinoma in the lung. Right, in conclusion, surgical pathology is a lot like detective work. I think as histopathologists, we need keen eyesight to recognize that which we have seen before. But we also need passion for our discipline in order to fully investigate those cases which are rarely encountered or which seem to defy classification. This detective work is very much, and I need to reiterate this, very much reliant on our interaction with you, our referring clients and colleagues, as well as your understanding of what we do and how we go about it. And I hope that tonight's presentation has succeeded in achieving this aim. Thank you very much.
Thank you very much, Dr. Yazbek. What an excellent presentation.